Happy Women's Day to you, ma'am.
Good evening, everyone. Happy Women's Day to everyone. On the behalf of IIP India Digital Team, I welcomes you all. On the behalf of Dr. Sanjeev K. Jha and Dr. Ruchi Vaishnav, who has provided us this wonderful platform for sharing their knowledge, I will not waste your time and I will hand over to our moderator, Dr. Vinita Baghel, ma'am. Please continue the webinar.
Okay, thank you, sir. Thank you very much, IIP Digital Team. No other creative in the universe is as good and beautiful as women. You deserve the utmost love and respect. Good evening to one and all. Dr. Vinita Baghela, State Coordinator, IIP Women's Cell Rajasthan, welcomes you all. Wishing you a very happy Women's Day to all the lovely women and girls here. I'm profoundly honored to get this opportunity to welcome our esteemed resource person, Dr. Dhara Shah ma'am, for accepting our invitation and bringing an inspiration as we hope to become like you, ma'am. I would like to welcome and thanks Dr. Sanjeev K. Jha sir for guiding us and keeping our spirits high. We are and we will be grateful for your contribution, sir. I would also like to welcome Dr. Ruchi Vaishnav ma'am, IAP Treasurer, National Head, IAP Women's Cell, for believing in us and maintaining unity, integrity, and morale of IAP Women's Cell across the nation. I would like to welcome Dr. Sakina Kanchwala ma'am for bringing the best in us and helping and guiding us. I would like to welcome all the office bearers of IAP Women's Cell Rajasthan for their excellent contribution in each activity of the state and bringing out greatness in this organization. So now I convey my gratefulness to our esteemed resource person, Dr. Dhara ma'am. So I would like to say a few words and introduce about her. Dhara ma'am is Chief Clinical Instructor and Team Leader for Teaching Training Programs at WOW IPRE. Ma'am is HOD of Pelvic Floor Rehab Clinic, Head Office WOW Group in Ahmedabad. Ma'am is the lead assistant to Dr. Hed Desai sir in designing and developing pelvic floor rehab workshops and seminars in physical therapies, gynecologist, urologist, urogynecologist, psychiatrist, sexologist, oncologist, colorectal surgeons, and more. Ma'am is lead proofreader of MCQ developer and organizer to one of the best books of pelvic floor rehab for doctors, Heath Manual of Pelvic Floor Rehab. Ma'am is also lead assistant in research and development of underpatient patent pelvic floor rehab products like VFit, VEase, and WOW Group mobile app. Ma'am is lead assistant in research and development for final phase of Heath MMT. Ma'am is key contributor in designing the Heath FSF, female sexual function, and Heath male sexual function scale. Ma'am is also chief executor in designing the clinical educational videos for male pelvic floor rehab. So it's our greatest honor to welcome Dhara ma'am here. Thank you so much, ma'am. So over to you, ma'am.
Thank you very much, Dr. Vinita, for a lovely introduction. And before we go ahead, I would really like to extend my thanks to IAPWC, the President of IAP, Dr. Sanjeev Jha sir, the National Head of IAPWC, Dr. Ruchi Vaishnav ma'am, Dr. Sakina Kanchwala, Dr. Vinita Baghel from my end, as well as from Dr. Hed Desai sir also, for joining the hands in the war against silent suffering and giving all the physiotherapists across nation an opportunity to learn about different pelvic floor dysfunctions, women's health dysfunctions, as well as new updates in the field of physiotherapy. Happy Women's Day to all of you. I am Dr. Dhara Shah. I am working as a clinical instructor in WOW IIPRE, that is International Institute of Pelvic Floor Research, Rehab and Education. And before we go ahead, before I start my screen, today we have met to discuss about the what can pelvic floor rehabilitation, how can the pelvic floor rehab benefit females who are suffering through sexual dysfunction. On this Women's Day, it is my pleasure to speak upon a topic which is not very well, which is still considered to be a cultural taboo and which is not being accepted so far. But I really look forward that with the vision with which Sir has started WOW IPRE and the vision with which he has opened this door of underserved and but yet required topics for us, we will understand our role and will go ahead into these fields as well. So, Hed sir, as I always say, it is always a great pleasure for me to introduce Hed sir for all of you. He's an entrepreneur, innovator, and author of Amazon's bestseller #1 in neurology, Amazon's bestseller in gynecology and obstetrics, and Amazon's bestseller in physical therapy. For the contribution which Sir has made into the field of pelvic floor, he is popularly known as father of modern pelvic floor rehabilitation. And it is his vision that is to courageously break the cultural taboo and to make pelvic floor rehab accessible to every single woman and every single man on the globe through innovative technologies and services. And I feel so fortunate and great to be a part of his wonderful vision. Sir is also the chairman and founder of WOW IPRE, that is International Institute of Pelvic Floor Research, Rehab and Education, which has received certificate of recognition from Government of India. WOW Experience Research and Development, which also has received certificate of recognition from Government of India. WOW Group of Businesses, World Pelvic Floor Organization, and Easy PFM Exerciser, which also has received certificate of recognition from Government of India. He is also leading one of the projects which is Vidyoke, and it is also recognized by the Government of India. It is really a very fortunate feeling to be with a leader whose 4 of projects are being recognized by the government, and those are the projects for the well-being of the world. To his innovative and intellectual properties, it is WOW PF360 Dilate and WOW Group mobile application. To his academic contribution, he has HATES MMT, HATES FMT, HATES self-assessment, HATES providers protection guidelines, HATES reflexive result scale, HATES female sexual function scale, and HATES male sexual function scale. Going onwards to our topic of discussion today, that is role of pelvic floor rehab in female sexual dysfunction. So before we jump onto the female sexual dysfunction, I would really like to give a short and quick review of the female reproductive system and the female sexual system as well. So when we talk about the female reproductive system, we are basically focusing on these organs. So as you can see here, these are the ovaries, the 2 fallopian tubes, the right and the left, and this is the uterus. So if I just rotate it and if I just show you the lateral view, so this is the uterus. You can see how the uterus is placed just posterior but superior to bladder. So just behind the bladder we have our vagina, and then we have the rectum. So if I have to give you an introduction of all the reproductive organs which are there, so it is like if this to be the pelvic floor model, and this is symphysis pubis, as we all can understand. Posteriorly, this is the coccyx. This is the ASIS to ASIS, and if I'm keeping all the structures inside like this is how the position is. So you can, if I just give you a view superiorly, so just behind the symphysis pubis we have bladder, and then the following structures. Okay, so I'm just removing the structures out so that you can understand it in a better way. And you can see here, this is the bladder. For just beneath the bladder you have the urethra, and just posterior to bladder you can see is the vaginal wall, and superior to vaginal wall is the uterus. So if this is the bladder, then this is the uterus, and this is the vagina. So they form like a shape. It is like a shape of 7, like this. The bladder, the uterus on the top of it, and posteriorly we have the vaginal canal. And then the most posterior aspect, we have the rectum and the anal canal. Now, this today we are not talking about the bladder and the rectum. We are simply focusing upon the reproductive health and the sexual health. So now if I'm just simply giving you a more closer view, this is how it is: the ovaries, the fallopian tubes, the uterus, and the vagina. Okay. The ovaries, when we say the major 2 functions of ovaries, we all know it is production of the ovum and maintenance of the hormonal levels in the body of the female. So that is the estrogen and the progesterone hormones predominantly, and the formation of the ovum, which is being transported to, now this ovary is being connected with the fallopian tube through the fimbriae. But the beautiful part here is ovary is not covered, or it is not connected, or it is not attached to the fimbriae. Rather, the fimbriae, they are freely floating surrounding the ovaries, and they come closer towards the ovaries during the time of ovulation, so that they can pick the ova which is being released into the abdominal, into the free cavity surrounding the ovary. So it's not, the fimbriae are not touching the ovaries, they are freely floating surrounding the ovaries. They will engulf, or they will collect the ovum, and then they will transport it further towards the fallopian tube. And in the fallopian tube, there will be the fertilization. Okay, the meeting of the ovum and the sperm happens into the fallopian tube, and then after fertilization, the embryo or the blastocyte which has been formed is being transported into the uterus. So uterus, or in common terms, it is the womb. In the non-medicos or laymen consider it to be the womb. Again, it is the uterus in the female has enormous expandability. It can expand. We all know that during pregnancy, right? It is just a pelvic organ which might be less than the size of your fist. But during pregnancy, or till the last trimester, it expands and comes up towards the symphysis. It comes up towards the this xiphoid process, or it almost becomes a thoraco-abdominal organ. It pushes the ribs and pushes the thoracic contents up. So it has enormous expandability. Okay. Not going in detail of all the structures, because we have a lot of things to talk about the sexual health. The next comes the cervix, and then the vagina. Now, when we talk about the vaginal canal, as you can see, it has more nerve fibers over the outer 1/3, and lesser nerve fibers in the inner 2/3. So outer 1/3 has more dense nerve fibers, leading to more pleasurable sensations during sexual activity, or more sensations over the outer 1/3. As you can see, the wall of the vagina is also not straight, rather it has multiple rugs. And these rugs are further responsible to increase the sensation for the male as well as the female during the sexual activity. These rugs, they vanish, or they lessen in the number, or they straighten as the female ages and she reaches the menopause. So for many females, the elasticity as well as of the vagina, as well as the pleasure which they get during the sexual activity, is also compromised due to the disruption into the rugs. This I'm just repeating, I'm just giving you an insight of all the structures, but we can have one webinars for all structures in detail if required. And as you can see here, these are the fornix. You can see here, this is the cervix, and these are the fornix. You can see the anterior fornix of vagina and the posterior fornix of vagina. This here would be the internal os. This here would be the internal os, and this is the external os, and this is the cervix, the endocervix as well as the ectocervix of the the ectocervix as well as the endocervix. Now coming towards the external structures. So externally, if you can see into this, for many of you that you might, if you are not into women's health, this image you might be coming across for the first time. But then this is the mons pubis, as you can see. If I have to show you on this, so the way you have pubic symphysis, the skin over here and the hair which are grown, this area is known as the mons pubis. As you can see, just beneath the mons pubis you have labia majora. Okay, and if you retract the labia majora, you have labia minora. How would you differentiate between the labia majora and the labia minora? So when we talk about the labia majora, it has hair follicles over it. So if you are examining a female and you see that the lip folds or the lips, they have the hair follicles, that is the labia majora. And if you would retract the labia majora, there will be another skin like structure which will not have hair follicles. It would be like your lips. Okay, so that is the labia minora. Okay, what is the role of labia majora and labia minora? It is to protect the internal delicate structures, and secondly, it helps during the sexual activity. How? In many females, though the researches are not very great in numbers, but in many females, even the labia minora, they are the part which gives some sort of sexual pleasure to the female. So now this labia minora, they forms the hood. You can see here this structure. Okay, this is we call it as the hood of the clitoris, or you can also term it as prepuce. So if the way in males they have the foreskin of the penis and then the glans of the penis, similarly the homologous structure in the female, it is the clitoris. So this what you can see is the hood of the clitoris, which is being formed by this labia minora. The continuation of the labia minora forms the clitoral hood, and inside is the clitoral glands. This is the glands of clitoris. Okay, and on the other side you can see that the structure of the clitoris is also in detail. So here you can see the glands of clitoris, the shaft of clitoris, the legs of clitoris. Okay, and these are the bulbs of vestibule. So when we talk about the bulbs of vestibule, that and all these structures, so this complete structure, these are the erogenous structures, or you can say the erectile structures for a female, which are giving pleasure during the sexual activity. These legs of the clitoris also have structures similar to corpus cavernosum as in male. So the male have corpus cavernosum and corpus spongiosum into their penile shaft. Similarly, the legs of the clitoris has the corpus cavernosum into it. So these are the empty spaces, or these are the spaces where during sexual stimulation or sexual activity, the blood gets filled or the blood is pumped, that leads to the erection of the clitoris. And if the clitoris is erect, or if the clitoris is getting good blood flow, that means the female will be able to enjoy the sexual activity into a much appropriate way. This bulbs of the vestibule, their function, they get actually swollen up during the activity so that they can create more compression and hold for the penis to enhance the pleasure for both the partners. Okay. And these glands, along the bulbs of vestibule, along with the Bartholin glands, they are responsible for increasing the lubrication, the vaginal lubrication during sexual activity. The lubrication of the vagina is required so as to avoid the dryness of the vagina. Now in this image, you can see that there are multiple different presentations of labia minora present, and all of these are normal. So if a female has any of these structures, that is absolutely normal until and unless it is fulfilling its function. So what is the function of labia minora? The function of labia minora is to protect the internal structures and to help during the sexual activity by increasing the pleasure. So if these two functions are being taken taken care of. That means the labia minora is absolute, the structure of the labia minora is absolutely normal. And Hetzer always say that the way we have different faces, see, all of us have two eyes, one nose, two lips, one tongue, two ears, two eyebrows, one chin, but for all the facial structures are different. So similarly, Hetzer says that all the perineal areas are also different. You may have two labia majora, two labia minora, one clitoral glans, one clitoral hood, urethral opening, vaginal opening, perineal body, and anus, but the presentation of all of these can be different. And that if it is fulfilling the function, it is absolutely normal. So now what comes next is the pelvic floor muscle anatomy. So when we talk about the pelvic floor muscle anatomy, so we are to specifically discuss about those muscles which are responsible for sexual activity. So giving you a brief about the pelvic floor muscles, you can see the symphysis pubis, the coccyx, the ischial tuberosity is on the right and the ischial tuberosity of the left, and this red colored beautiful muscle which is visible, the layer of the muscle which is visible, this is the pelvic floor muscles. These are the pelvic floor muscles, sorry. When we talk about the pelvic floor muscles, they are group of muscles which are into three layers. So we have a superficial layer. If I'm just retracting the superficial layer, this is the middle layer, and then we have the deepest layer. Okay, just a minute. So when we talk about the pelvic, sorry for that, but when we talk about the pelvic floor anatomy, we are talking about three layers: the superficial layer, the middle layer, and the deepest layer. And the muscles of the superficial layer, I'm giving you the names of the muscles, so for a better understanding. So you can see here, this is the perineal body. You can see a muscle which is like in the form of U, like this, a U. So this you can see it is getting splitted around the vaginal opening and the urethral opening and going up like this. So this is the bulbocavernosus. Okay, this is the bulbocavernosus muscle. The function of the bulbocavernosus is it is really responsible during sexual activity. What does it do? First, it will help for the closing and opening of the vaginal orifice, only the outer orifice. Like if this is the vaginal opening, then not inside but externally here. So this would be the flickering, like this flickering muscle. Okay, and you can even palpate that muscle when we go for a perineal examination. Okay. And many females who have painful sexual activity or painful sexual penetration, they might even have tightness surrounding the bulbocavernosus muscle. Okay, so that is this muscle, the bulbocavernosus muscle. One of the activities is closing opening, and second activity is increasing the blood flow towards the clitoris and helps in maintenance of the erection of the clitoris, along with ischiocavernosus. This is the second group of muscle. You can see a second oblique muscle which is running all across the ischial tuberosity. So it is attached here towards the clitoris, and running up towards the ischial tuberosity throughout the ischiopubic ramus. This is the ischiocavernosus. Again, ischiocavernosus helps to contract and helps to maintain the erection of the clitoris. The next in line, you can see the superficial transverse perineal muscles. These muscles are basically responsible to maintain the stability of the perineal body. Okay. The next is the external anal sphincter. So you can see the external anal sphincter is responsible for maintenance of the fecal continence. Okay. I'm just removing this to show you the middle layer. Here you can see the middle layer of the pelvic floor muscles. So the middle layer of the pelvic floor muscles, you can see one muscle which is running all across the ischiopubic ramus and coming in the center. Okay, so this is the deep transverse perineal muscle. Okay, the deep transverse perineal muscle, and some of its fibers, they are responsible for making the external urethral sphincter. Okay, So the deep transverse perineal muscle basically will work with the superficial transverse perineal to work for the stability of the perineal body, and secondly, it will form one of the fibers for the external urethral sphincter in the form of urethral compressors or compressor urethrae. Okay, so urethral compressors or compressor urethrae that are being formed by the deep transverse perineal muscle. Okay, some books they also say that the deep transverse perineal muscle, it makes the uretherovaginal sphincter. It again depends upon you which anatomy you want to follow. Now going towards the deepest layer, the innermost layer. So if I have to give you a view of the, this is how the internal pelvic floor muscle is, the deepest layer of the pelvic floor muscle is. To simplify it, I'm just retracting, and you can see that you just don't think about any of the structures at present or openings. Just think that this is the symphysis and this is the coccyx. So can you see one muscle which is running through from symphysis to coccyx? So if it is attaching to symphysis and to the coccyx, we name it as pubococcygeus. Okay, so this is the pubococcygeus muscle. You can see here, this one, the pubococcygeus. Now, what other structure you can see? This one. So this is the, let me take this side. So you can see here the pubococcygeus and this structure. What is this? This is the obturator internus muscle. Okay, the obturator foramen, you can see the obturator foramen, and this is the obturator internus muscle. Now this obturator internus muscle, you can see here, there is a fascia of the obturator internus, and from the fascia of the obturator internus, there is another muscle which is originating or running. That is the iliococcygeus. You can see this is the iliococcygeus, and last, the small, you can see a triangular muscle fiber running. So that is the coccygeus, or some book terms it as the ischiococcygeus also. So you can term it like, you can remember the way you want to. But there are three muscles, basically the larger ones to remember, running from the symphysis to the coccyx. So there is the pubococcygeus, iliococcygeus, and coccygeus or ischiococcygeus. Okay, but in females we have three openings. So these pelvic floor muscles, they had to split to give the way for the three openings. And so you can see here the openings, the urethral opening, the vaginal opening, and the rectal opening. So which was the medial most muscle? That was pubococcygeus. And now if these three openings are going from the midline, which muscle needs to give its way? That is again the medial portion of the pubococcygeus. And so you have the pubourethralis, or you can term it as pubovesicalis, pubovaginalis. So pubourethralis or vesicalis, it loops around the urethra, supports the urethra, and functions along with the external urethral sphincter. Then pubovaginalis, which loops around the vagina, which is responsible. It is very important muscle when we are talking about the sexual activity, because the pubovaginalis muscle is responsible to create a grip. Okay, so internal grip, or the outer 1/3 pay, the muscle which is there and which is giving the grip towards the penis, that is the pubococcygeus muscle. Okay, and posteriorly more we have the puborectalis. So puborectalis is a muscle which we discussed into our gut motility webinar. So it is the muscle which is responsible for maintaining the anorectal angle, thus maintaining the fecal continence, and is responsible for the process of defecation also. Okay, certain books they term that other than these three, there are two more muscles which are puboperinealis. So this is the muscle which is puboperinealis, that is to stabilize the perineum, and puboanalis. So puboanalis is a separate fiber other than the puborectalis. So then again repeating the same, that anatomy you can remember as you want to. But the major muscles for sexual activity when we have to discuss or deal, those are the bulbocavernosus, ischiocavernosus, perineal body, and pubovaginalis. This is just an example of how the muscles, they look superficially and how the deep muscles are visible. So you can see the ischiocavernosus, the bulbocavernosus, the superficial transverse perineum. This is the gluteus maximus. Don't get it confused with the pelvic floor. It is not a part of a pelvic floor. External anal sphincter. Here you can see the urogenital diaphragm, or you can see the deeper layer of the pelvic floor. And then inside is the deepest layer where you can see the pubococcygeus, iliococcygeus, and coccygeus, and the cut fibers of the gluteus maximus along with the sacrotuberous ligament. Now, going towards the sexual dysfunction. So before we understand the sexual dysfunction, what do we mean by normal female sexual response cycle? Okay, so for a female, the normal female sexual response cycle goes like, there is a phase of excitement, there is a phase of plateau and orgasm, or you can also say that there is a phase of desire. Followed by desire comes the arousal, followed by arousal comes the orgasm, and then is the resolution. Okay, now what do we mean by the word desire or excitement? So desire or excitement typically means that when a female gets a desire to have a sexual activity, the see, I'm not using the word sexual intercourse, I'm using the word sexual activity. Intercourse is a penile intercourse, or vaginal penile sexual intercourse. That is when a male or a female partner gets into sexual activity. But sexual activity, it can be masturbation, or it can be a non-penetrative activity with the partner also. Okay, so what do we mean by desire? Desire means the need or the want to get into the sexual activity. That is desire. And that phase of desire can last for longer period of time. Okay, so it is that desire can be due to a visual stimulus, or auditory stimulus, a thought, or maybe in response to the partner's initiation. Okay, so the desire can be a self-driven desire or a partner-driven desire. Right? No matter what the desire is, so that is, I'm repeating, the phase of desire can last longer and need not necessary to be converted to the phase of arousal. Okay, if the female gets a desire to get into a sexual activity, and if she has an appropriate environment to do so, the next comes is the arousal, the sexual arousal phase. Arousal phase is more of the physiological phase, in the sense the psychological thought or perception or reciprocation, whatever the mind was perceiving, is now becoming more physiological. So now the body is started showing response in respect to the physical, to the desire, sexual desire. And what are the bodily responses to it which we see into arousal? So that is increased lubrication, vaginal lubrication. The next is increased blood flow towards the perineal body, tightening of the breast tissues, erection of the nipple, increased respiratory rate, increased blood rate, increased blood pressure, increased heart rate. Okay, shifting, softening of the vaginal canal. So the vaginal canal gets elongated. Moreover, the pelvic structures, now see, there has to be a penetration. So see, if a female is not sexually aroused, into her unaroused state, the vagina generally would be collapsed. But now when she goes for arousal, or she is anticipating a penetration, or she wants to have a sexual penetration, the vaginal wall, which was collapsed or shortened, will elongate. Okay, it will become long, it will elongate, it will become more, the smooth muscles would relax to allow penetration. And other pelvic structures, the uterus, the bladder, the rectum, they would shift apart a bit, so as to provide the space for the penis to penetrate. Okay, so that happens. The blood flow from overall body, from the skin and unwanted vital structures like intestines and GI tract will be diverted towards the perineal area. The uterine contractions also starts. That's the reason why many females come up saying that post sexual activity they get lower abdominal pain. They get a pain like as if they are menstruating. That can be because of the uterine contractions which happens during sexual activity. Okay. So those are the responses of the phase of arousal. The next is the phase which is related to the lubrication and penetration. So once the female is aroused, once she has enough lubrication and she is ready for a penetration, then after penetration she reaches to a phase of orgasm. Okay, so orgasm is a phase where the sexual tension has built to the has gone to the peak. The muscular tension, sexual tension, all the physiological changes in the body has reached to the peak phase, and then suddenly there is a release of the all sexual tension. So the peak point is the point of orgasm, and then there will be a sudden release of sexual tension. So a sudden release of sexual tension and the muscular tension in the body, and then will be the phase of resolution. So resolution is the phase where all the changes are coming back towards the baseline. Okay, all the changes. The heart rate is coming down, the respiratory rate is coming down, the blood pressure is coming down, the sexual tension has already reduced. Now it is reducing and coming towards the baseline. The muscle tension is reducing. All the physiological changes, the nipples which were erect now are becoming smoother and settling down. So all these changes that comes into the phase of resolution. But for a female, many of them, they are multi-orgasmic creatures. Now, what do I or multi-orgasmic beings? So what do we mean by multiple orgasms? That means if a female has not reached her plateau, has not reached her baseline tone, and if she gets a sexual stimulus again, she can again go through all the phases and can achieve orgasm. Okay, so that is multi-orgasmic beings. Fine. So on the base of this much understanding, what can be the sexual dysfunction? So the sexual dysfunction you can categorize according to each and every phase of the sexual response cycle. So according to WHO, the various ways in which an individual is unable to participate in a relationship is as he or she would wish. That is sexual dysfunction. And not to forget that WHO has stated that sexual health is a state of well-being. So if you want to term someone healthy, it's not just about the physical, mental, emotional health. It is also about the reproductive and the sexual health as well, because that falls under the category of state of well-being. Okay. When we talk about the classification, according to the Bazin's classification 2000, it is like sexual desire disorder, sexual arousal disorder, sexual pain disorder, and female orgasmic disorders. Now, when we talk about the sexual desire disorder, it can be classified as hypoactive sexual desire disorder or sexual aversion disorder. When we talk about hypoactive sexual desire disorder, that means the female libido, overall desire to have sex has reduced. Okay. And that is bothering her lifestyle. So her libido has reduced, her desire has reduced, and that is bothering her other activities or bothering her mentally and physically. So that is hypoactive sexual desire dysfunction. Other is the sexual aversion. So what do we mean by sexual aversion? That means in hypoactive, the desire is still there, but it has reduced. And in aversion, she does not want to get into a sexual activity. She is not ready for even a warm touch or anything which can turn out into a sexual activity. So that is a complete aversion towards the sexual activity. Arousal disorder means the female is unable to either attain or maintain the arousal. That is the sexual arousal disorder. After that is the penetrative disorders or the sexual pain disorders. So we can broadly categorize them as dyspareunia and vaginismus. Now, what do we mean by dyspareunia and what is vaginismus? So vaginismus is a condition where there is spasm of the outer 1/3 of vaginal canal, so that the pelvic floor muscles goes into spasm and they do not allow a penetration to take place. that is vaginismus, no penetration at all. It's not sexual penetration, even asexual penetration. Asexual penetration means maybe insertion of tampon, insertion of menstrual cups, insertion of vaginal suppositories for some dysfunctional disorders, transvaginal ultrasound probe, anything. Nothing can penetrate, or the muscles are so tight and the patient is not allowing anything to penetrate inside. That is vaginismus. And second is dyspareunia. So dyspareunia is the term which is used to describe a painful penetration. So that means the penetration is there, but it is painful. It's not easy, it's not comfortable. It is painful, it is discomforting. That is dyspareunia. And then the comes are the orgasmic disorders. So when we talk about the orgasmic disorders, those are the dysfunction where the female is either unable to achieve orgasm, is delaying in reaching orgasm, or is unable to either she is unable to achieve the orgasm or there is a delay in reaching the orgasm. That is female orgasmic disorders. Okay. Yeah. So what are the symptoms of female sexual dysfunctions? So the symptoms can be lack of interest or desire, reduced arousal or inability to get aroused, inability to achieve enough lubrication or penetration, inability to relax the pelvic floor muscles during intercourse, painful intercourse, inability to achieve orgasm. And what can be the causes of sexual dysfunction? It can be a physical cause, it can be hormonal cause, it can be psychological and social cause, or it can even be pelvic floor dysfunction. Now, when we talk about the pelvic floor dysfunction, we are broadly categorizing the pelvic floor dysfunction into two subparts: hypotonus and hypertonus. Hypotonus means if the muscle is becoming too loose, too weak, and is not knowing how to contract and how much to contract, that is in hypotonus pelvic floor. Okay, so you can see the hypotonus pelvic floor muscles, the loose pelvic floor muscles, the female coming up with complaints of urinary incontinence, pelvic organ prolapse, fecal incontinence, sexual dysfunctions. In these, the muscle has become so, the pelvic floor muscles have become so loose that they cannot give a grip over the penis. And if the grip is compromised, so is the sexual satisfaction. And others can be the hypertonus dysfunction, as we discussed already, talked about the vaginismus and dyspareunia. So these are the two where they fall under the category of a hypertonus dysfunction. The pelvic floor muscle has gone into so much tightness, so much spasm, and so much pain that it is unable to relax completely. Now, what can you do to quickly assess those dysfunctions? So the commonly used grade which you all might be doing is Oxford grades for pelvic floor. But if you see and understand the Oxford grades, there are two major limitations. The first one being that you cannot assess the relaxation of the pelvic floor component. So pelvic floor muscles, the relaxation component of the pelvic floor muscles cannot be assessed through modified Oxford. These modified Oxfords or Oxfords. And secondly, the terminologies which are being used, they are quite vague, like weak, fair, moderate, good, strong. Now, these are very subjective terminologies and the interpretation can vary from person to person. Okay. So, Hetzer has designed and developed Hetz MMT, which is crossing or overcoming both the boundaries of both the limitations of Oxford MMT. So that is Hetz MMT. Sir has, from his years of research, he has developed a scale which can be used equally for the hypertonus as well as the hypotonus dysfunction. So when we talk, I will quickly explain you this scale to you. So 0 is the baseline tone. If you are doing, if there is a patient for a transvaginal examination, okay, and 0 is the normal baseline tone, the normal resting tone which we all have, that is baseline tone 0. Now, if the patient is not allowing a penetration to take place, the patient is holding it very tight and not allowing the penetration to take place, that is a grade of -1, inability to penetrate. That can be vaginismus. Okay. -2, when we say, that is symptomatic penetration, and that symptom can be of pain, tightness, or discomfort. That is -2. And -3 is an easy penetration, a complete relaxed pelvic floor muscle. So you are asking her to relax and she is very relaxed and you can easily assess her. So that is a grade of -3, a completely relaxed pelvic floor muscles. And now to check about the contraction. So it's very easy. Once you are transvaginally inside, you can give her a command to squeeze as if you are trying to hold the urine. And when she is squeezing, just try to see that how is the pressure over the finger. If you can see that there is just a mild pressure from either side, okay, there is no circumferential grip, there is just a mild pressure from either side, that is a grade 1. If there is a circumferential grip, that is a grade 2. And if there is a circumferential grip with upwards and inwards pull against resistance, that is a strong pelvic floor muscle, that is a grade 3 pelvic floor muscle. Quickly going through these slides. So 0 is the baseline tone, -1 is inability to penetrate, -2 is symptomatic penetration, -3 is asymptomatic penetration, 1 is mild contraction, 2 is grip with complete circumference, and 3 is in strong upwards and inwards pull against resistance. There is one more grade, which is Lemon grade, which is being used by the physicians to assess the vaginismus. But just for an understanding, Lemon's grade will give you the readiness of pelvic examination. It's not going to explain you about the condition of the pelvic floor muscles. Okay, so it is more focusing on the psychological involvement rather than the actual physiological or pelvic floor dysfunction, and it cannot help to identify the pelvic floor involvement. When we talk about the scales, so it is FSFI, Federation of Sexual Function Index. Okay, so now FSFI scale by IUG, that is International Urogynec Association, has FSFI is Female Sexual Functioning Index. It is through this International Urogynec Association. But again, this scale is being developed by the urogynecologist. So it is not being developed thinking about the pelvic floor rehab specialist into mind. And that scale is not having different components to assess the hypertonous pelvic floor and its effect on sexual health, and hypotonous pelvic floor and its effects on sexual health. So both this the limitation of the FSFI, Female Sexual Function Index, is being beautifully taken care by Haig's FSF scale, that is Female Sexual Function Scale. Sir has designed this scale in such a way that it has two separate components for hypertonous and hypotonous, and it is also giving you an in detail explanation or description about what is the limiting factor, whether desire is the limiting factor, arousal is the limiting factor, orgasm is limiting factor, or lubrication is limiting factor. So these 5 major phases, or these 5 major points of the female sexual scale are being taken care individually in the scale designed by Haig sir. So if on the scale rating, if you have a score of 0 to 25, it is poor sexual health. If it is 25 to 40, it is average sexual health. If it is 40 to 50, it is good sexual health. Now, to objectively assess the pelvic floor muscles, I'm not going in detail, is the V-fit, V-ease and V-fit. That is to check the strength component and the relaxation component objectively of the pelvic floor muscles. So this is vagina dilate. If the patient is unable to have the narrow end penetration, that is grade C, it is extremely tight pelvic floor muscle. If the narrow end and the broad end, that is penetrating, but it is with pain, tightness, discomfort, with any of the symptoms, that is grade B, tight pelvic floor. And if there is easy and pain-free penetration of the broad end, that is grade A, completely relaxed pelvic floor muscles. The next is the V-fit, which is used to check the strength of the pelvic floor muscles. So in this, the patient has to insert the V-fit inside in standing position, and then she has to go for 3 functional activities: 10 calf, 10 squats, 10 jumps, just to see the pelvic floor functional strength. So if as soon as the patient inserts the V-fit inside and it falls out, that is a grade C, extremely weak pelvic floor muscles. If it is not falling out, it is just sliding out during any activities. So while coughing, sneezing, jumping, it's just sliding out. That is weak pelvic floor muscles. And if it does not slide out, but it remains inside, same as it was, and the female is able to complete all the three functional activities. So that is a grade A, strong pelvic floor muscles. Now, going towards the introduction of the pelvic floor rehab, if you are seeing a patient with a hypertonus disease, the sexual dysfunction can happen due to multiple causes, as we already had seen. It can be due to pelvic floor, it can be due to psychological, it can be due to medical, it can be due to hormonal, or it can be a physiological, like pregnancy. Okay, whatever the dysfunction is occurring, if there is a pelvic floor muscle involvement, and in majority of the cases what we have seen, pelvic floor is involved at certain or the greater extent. If not in the female, then maybe in the male. The male has erectile dysfunction, the male has premature ejaculation. That's why the desire of the female is reducing. Okay, so then in that case, your focus as a pelvic floor rehab practitioners should be towards treating the pelvic floor muscles in congruity with other specialty doctors to take care of the psychological component, psychiatric component, or any others. Okay. So now, if the patient is suffering through a hypertonus, if she is coming with a complaint of pain during sexual activity, or pain or inability to penetrate, or inability to finish the sexual activity due to pain, that means you need to first check for the hypertonus muscle. If the muscle is hypertonus, your goal gets more simpler. That is to reduce the pain and relax the muscle. RR, reduce the pain and relax the muscle. So for pain reduction, you can use IFT, you can use ultrasound, you can use cryotherapy, you can use relaxation techniques, and stretching of the associated muscles. And you can even use the smooth soft tissue release techniques, Glazer's protocol, ischemic compression therapies, sweet spot release, Weiss-Anderson's release. And next is you can treat for proper penetration and position, that which position should the female go for in sexual activity. It's not a surprising finding when I say that many couples, when they come with sexual dysfunction, many of them, they do not understand that where is the female vaginal opening, or where is the vaginal opening. And that can also, and because of the difference in the anatomy, and many a times even the female, if she is not aware of, if she does not understand her own perineal area, she might get underconfident, she might get inferior, or she might feel that her area is not normal and she has some abnormality. And that can also lead to inferiority complex and an aversion towards the sexual activity, or a dislike towards the activity. That what if my partner comes to know that I'm abnormal? What if this? What if that? And all those things can come up. Okay. Similarly, if the opening, the anatomy is different, and if they're unable to understand that where should the penetration happen, that can even lead to repetitive thirsting or hitting of the vestibular area, which leads to pain and then anticipatory spasm. Okay, so explaining and understanding about the genital structures to your patients is equally important as it is for your understanding. I'll quickly finish it. The next is the treatment for the hypotonus dysfunction. So if you find out that the muscles are weak, then you can work upon again two aspects: strengthening the muscles and increasing their endurance. That is, increasing the contractions and fast twitch muscle activities. And we are also using WOW PF360, which is a non-invasive pelvic floor rehab technology, which has a specialized target activator to specifically work upon the Bartholin glands for increasing the lubrication during sexual activity, towards the paraclitoral muscles, to work upon the paraclitoral area specifically, okay, to work upon the vaginal orifice. That is what is WOW PF360. And last, to conclude my slides, just a quick introduction of what WOW IP is. So it is WOW IP is #1 in pelvic floor education. It is International Institute of Pelvic Floor Research, Rehab and Education, an initiative of WOW Group by Dr. Hed Desai sir. IPRI has received certificate of recognition from the Government of India to for the specialized training of transvaginal transrectal pelvic floor rehabilitation, to train and place skilled pelvic floor rehab specialists, and to improve education and employment and doctors, businesses and services. IPRI is a global brand, and we are training across more than 7 countries now, including but not limited to UAE, USA, Nepal, Philippines, Malaysia, Africa, Singapore, some European countries as well. And Sir's book, Hates Manual of Pelvic Floor Rehabilitation, it is one of its unique book of its kind, and it is Amazon's bestseller #1 in urology, Amazon's bestseller in gynecology and obstetrics, Amazon's bestseller in physical therapy. It is also a recommended textbook for the Masters of Physiotherapy in Women's Health in Gujarat University. It's contribution I already had mentioned you. The book and the concept and the technologies are being forwarded by many national and international dignitaries like founder president of CEPHOC, South Asian Federation of Urogynecology, founder member of Gynecological Endocrine Society, ex-president and ex-vice president of FOXY, national president of Indian Medical Association, United Kingdom's lead consultant urologist, ex-president Urological Society of India, and past president of Endourological Society, and past president of Society of International Urology, and registered clinical exercise physiologist, American College of Sports Medicine, and many more. To his innovative and other brands of WOW Group, it is WOW Experience Research and Development, Easy PFM Exerciser, which has received certificate of recognition from Government of India. And other brands include World Pelvic Floor Organization and WeCare as well. So thank you very much for being with us throughout this 45 to 50 minutes talk. I found that my talk, I think that my talk has given you an insight, and has opened another area to work in women's health, that is sexual dysfunction. I would really like to thank all of you on behalf of me, whole WOW Group, and Hed sir for joining this war and breaking the silence, and working towards the end of silent suffering. Once again, thank you everyone, and I'm really very grateful to Hed sir as well to bring this opportunity and give us all and vision to work upon something which is different than the normal physiotherapy, a complete different aspect of pelvic floor rehab. So thank you one and all.
Thank you so much, Dara ma'am, for your wonderful insights. And I can't say superficially, you have touched so deeply the main aspects of the sexual health. And I hope the students are liking it very much. You can see the messages are floating and they are thanking you from the bottom of the heart. We are extremely honored to have you, ma'am, and for this valuable sharing for women health. Thank you so much, ma'am.
Thank you very much. And if you have any queries, or if you have, because we could not address throughout in 1 hour. So if there are any queries or questions, you can get back to me on my WhatsApp number, H0005215003.
Yeah, sure, ma'am. If anybody wants to ask questions, they can ask right now. If there are any questions.
So once again, wishing you all a very happy Women's Day, and let's end the silent suffering. Yes, sure. There is a question. There is a question from
a candidate. Precise treatment, yes, for vaginismus.
Yes, Dr. Surekha, vaginismus, when we talk about, we need to find that how much is the psychological involvement, what is the cause of vaginismus, and how much is the level of the muscle being involved. And according to that, like whether only at times it can happen, like if you go for a pelvic floor examination, you might find for some females that only the superficial ring is involved. And if you just release the superficial ring, internally the patient does not have much complaint and she really goes quicker with vaginal dilators, vaginal positionings, and all those things. But if the patient has a very severe spasm, then you have to specifically go for release of the trigger points, releasing the tender points inside, stretching of the pelvic floor muscle, relaxation of the pelvic floor muscles. Again, if there is associated other muscles, the maybe the accessory muscle tightness, you need to release those, and then you have to keep her on the vaginal dilators. VE is what we are using to mechanically help her stretch the perineal vaginal opening, and then to train her the importance of foreplay, explaining her about the erogenous structures or the erectile tissues, and then taking her further towards the sexual penetration. So precise treatment, we do a lot of discussion and we do a lot of hands-on techniques. I think that I might not be able to, explain everything in this webinar, but surely you can contact me on my number for any further assistance.
Thank you so much, ma'am.
Okay.
So once again, thank you each and everyone for participation, and thank you so much IAP Digital team for providing us this platform. And last but not the least, again, thank you so much, Dara ma'am, for spending your valuable time here. Thank you, ma'am.
Thanks a lot. Thanks Rajasthan team. Thanks to the speaker for this wonderful webinar and to celebrate the International Women's Day. And I just request everyone, please subscribe IAP India's YouTube channel and other social platform for sharing the knowledge like this. And I just again shows my gratitude to our Dr. Sanjeev Keja and Dr. Ruchi Vaishnav ma'am for providing us this wonderful platform for sharing the knowledge. Be in touch with the IAP India. Thanks to everyone. Thank you.